Hello everyone, welcome back to Clinical Psychology Community UK. Thank you so much for joining me today. Today we're going to be talking about psychological formulation. It's just a brief introduction and I can point you to some full-on webinars that are really good about psychological formulation for anyone who is interested. So before we get started, my name's Holly. Hi. I'm an assistant psychologist within the NHS. So psychological formulation is something that I'm sort of used to doing, but I thought it would be really helpful to do a brief introduction today. Don't forget to subscribe, and also you can find us on Facebook and Instagram too. So let's get into it then. So today we are going to be looking at what is psychological formulation. What is this magical concept? What is it? We're going to be looking at it from some different psychotherapeutic approaches. So we're going to be looking at CBT, systemic and psychodynamic mainly, and we'll touch a little bit on integrative approaches as well. We're also going to give you some practical advice for other people like me who are pre-qualified psychologists or aspiring clinical psychologists, what you can do to brush up your formulation skills and to learn a little bit more. So I'll give you some advice there. And like I said at the start, some helpful resources. So where you can go to read about this sort of stuff, other videos you might be able to watch. Hopefully I can point you in the right direction. Let's get into it then. What is psychological formulation? Okay, it's again sounds a lot fancier than it probably is. A lot of these terms like reflective practice, reflective portfolios, they actually sound a lot more fancy than they are. Psychological formulation has been defined by loads of different practitioners, all right, but commonly formulation is a structured approach to understanding the factors underlying a client's problem or problems and contribute to intervention plans. So that is the main idea. It's essentially like a map of what's going on for that person at the moment, what's going on for them, what's happened to them, what does it look like for them at the moment. Are they distressed? Are they struggling with emotions? Is it behaviour that they're struggling with? It will include all of that, depending on which approach you're sort of coming from. But for us as pre-qualified psychologists, it's really important because it's an essential part of the clinical framework for psychologists, and it's a key competency. So the clinical framework, or the clinical cycle, if you like, for psychologists is this: assessment, formulation, intervention, evaluation. That is the cycle that most psychologists are trained in, that they will be working in. That is the framework that they follow. So formulation is a really key step of that, and it's kind of acts as like a bridge between assessment and intervention. So assessment, you can kind of see it as gathering loads of information. It could be using an interview technique. It could be using outcome measures to gather as much information about that person that's relevant as possible. Then the intervention is looking at the person's goals and working towards those goals by actually doing some sort of work. It could be a therapy group or individual therapy, or it could be, low intensity psychoeducational course. It could be some self-help. It could be anything that helps them move towards their goals. So how do you get from assessment, all of that information, to a plan for intervention? Formulation. That's how you do it. Essentially, it maps the situation and any factors that trigger or maintain a problem. Hopefully, it will make a little bit more sense as we go through. So I'm just going to talk a little bit about some common components. And this is from a fantastic book, which I will mention at the end. But for now, it's this book. I will make sure that it's super clear. It's by Johnson and Dallas, and it's one of the core texts for the clinical psychology training program. So if you can, I would get it. I was really fortunate. I was bought it as a leaving present for the team that I used to work with a year ago. They smashed it on the gift. So I was really lucky in that. But I don't think it's massively expensive, so you can find it. Anyway, some common components then in psychological formulation. This is common across all of the different psychotherapeutic approaches that there are, and that formulation tends to have these similar components. So it summarizes the client's core problem or problems. It also thinks about how the client's difficulties may relate to one another and how they began, and it will also draw on psychological theories and principles. What I mean by that is that let's say we are using a CBT approach, as is so common. the CBT formulation, which we will go into, will, let's say the problem is eating disorders. So the client's difficulty is the fact that they are engaging in restrictive eating, let's say that. So that's the sort of behavioral element to it. But CBT suggests that your thoughts, your emotions, your physical sensations, and your behavior all interact with each other, and that actually the cognitive side is that these issues have come about from sort of unhelpful, problematic ways of thinking. So it's drawing on that CBT theory to make sense of the problems that the client's presenting with. I hope that kind of makes a bit of sense. They also, formulations, they will always contribute to a plan of intervention based on psychological processes and principles that have already been identified. So again, for example, in the eating disorder aspect, let's say restrictive eating is the behavior, but the reason behind that restrictive eating also needs to be looked at. So it lays out all of the problem. It could be that the person feels that they have very little control in other areas of their life. It could be that they're going through something quite traumatic or something like prolonged abuse, where they don't feel like they've got any control. So giving back elements of control to that person and working on that sort of side of things may be able to reduce that restrictive eating. But I hope that's kind of given you a little bit of an example of how it's based on psychological theory and using psychological processes and principles to form an intervention plan. And it's also open to revision and reformulation. I haven't read anywhere of an example of a formulation that has not been changed and changed and changed, because new information comes to light and you have to think about how the intervention's gone for that person. Has it gone well? Fantastic. So that element of the formulation can almost be not crossed out as such, but it can kind of just be like, yep, cool, we've looked at that aspect of it. Now let's look at a different aspect. So quite often formulations, they're supposed to be dynamic and changeable and flexible. So those are the common components. Now let's look a little bit at some differing components. Again, still from the same book. So what differs based on psychotherapeutic approaches and different theories is which factors are most relevant. So like I said, in CBT, thoughts, feelings, behaviors, and physical sensations are the key points. They're really, really important to that formulation. But things like social circumstances might not be as involved, or what's going on in terms of the family might not be that important. But based on CBT. So the idea is that different assumptions are made about the development and maintenance of problems based on each therapeutic approach to formulation. And that means that you're having different ways of formulating the same problem. So when we get to some practical advice, I'm hoping this will make a little bit more sense. It also differs in which explanatory concepts they draw on. So what I mean by that is things like psychodynamic approaches will draw on the unconscious a lot. Social constructionist approaches will look at the discourse and the language that we use to construct our reality around us. And schema therapy will look at the different schemas or sort of group of thoughts that we have about a certain thing. But that will always differ based on whichever approach you're using to formulation. There's an emphasis on reflexivity as well. There's differing emphases on that depending on which approach you're going for. For example, cognitive analytic therapy, CAT therapy, encourages a lot of reflexivity from the therapist. It invites them to discuss their experiences as well. In terms of being in the therapy room with that person, because it's a very relational model. So, but that's not necessarily the case in other approaches like CBT. And also how collaborative the process is. I mean, we have moved towards a way more collaborative way of working, which is much nicer and addresses power balances somewhat. But some formulations will be entirely collaborative, and it will be the client might map it out themselves. They might write their formulation. So in CBT, for example, the formulation is super collaborative. You're both sitting there together. You're on a level playing field, trying to work on this problem together from different viewpoints. But more traditional models might not be like that. More traditional models might encourage the clinician to go and think about formulations without necessarily sharing in the same way with the client, maybe cherry picking what to share with the client at that time. So yes. Another thing is position relating to psychiatric diagnosis. So this has long been a big debate within psychology, within clinical psychology, the idea that there are mental illnesses that have symptoms that need treatment. That whole idea can be very different. I mean, CBT has been massively evidence-based, supposedly, because it's quite logical. It kind of makes sense. It's easy to implement. If with little training, it can be adapted to different diagnoses. And there's CBT for eating disorders, for each different sort of type of eating disorder. There's CBT for trauma. There's loads. So that inherently suggests that those diagnoses are real things, because the therapy model has been adapted for them. But something like compassion focused therapy is more transdiagnostic in the way that you apply it. So it's not, CFT isn't like CBT in that same way. But perhaps that's the way that it's been applied in my line of work. Moving on to the next thing, which was position regarding truth versus usefulness of the formulation. So some psychological models might suggest that the formulation is true. What we've put here is true, but some other models might think, well, this is just a representation of what of the therapist's view and the client's view and what they want the world to see. So it might not be that it might not be as true as we think it is, if that makes sense. And position regarding usefulness. So some people, as we've said in clinical psychology, it's assessment, formulation, intervention. That's massively important. So it's one of the three central parts of clinical psychology, the practice of an application of clinical psychology. But in terms of the usefulness of the formulation, it's how is that used? Is it used? So, for example, in CBT, it's a really important phase in that therapy that you're doing that formulation and you're working out together what to work on. But in some cases, the formulation might not be that important. There might be more pressing issues to deal with at that time. It really depends on the situation. But I hope that kind of makes a bit of sense. And the last thing is the way the formulation is developed, shared, and used within therapy. Yeah, so as I think I've sort of explained that one already. So let's look at some specific models of therapy. We're going to start with the obvious. We're going to start with CBT. And as I've already said, CBT posits that thoughts, feelings, physical sensations, and behavior all interact with each other to maintain problems. The idea is that it's intrapersonal. So my thoughts inside my head, my emotions that I feel, my physical sensations within my body, and the behavior that I do is all to do with me and how I perceive things. How, it's not to do with the other environment around me. If you're interested in learning a bit more about CBT, I have done an introduction to CBT video, which I'll link at the end as well. Now, psychological formulation is considered the linchpin of CBT. As I've said, it's super central to that. You can't really do proper CBT without having a formulation. It needs to be there. And the formulation is collaborative, as I've said. It will usually be a therapist and a client talking together collaboratively, mapping it out potentially on flip chart, doing it really collaboratively to try and work out what all the problems are and how it's all linked and mapped. It's developed in levels. So usually in CBT, you usually start with the presenting issues and then work more towards the predisposing factors. So the idea is that we have different levels of thinking, if you like. So we have negative automatic thoughts. We have core beliefs right down at the bottom. So core beliefs are very difficult to access. So a core belief could be I am embarrassing, or I am destined to be alone, or it could be something like that. It's a broad statement that is a core belief that you have about yourself, but it's very difficult to change those things. They're very deep within us, within our psyches and within everything about us, so they're very difficult to get to. So what you do is start with levels. So you start with some of the thoughts that people can notice. you know, some of the automatic thoughts that people can notice and that distress them. So a lot of the time people will come in and say, I'm feeling really anxious. And you say, okay, have you got any thoughts associated with that? And it might be, I'm scared people are going to laugh at me. Well, okay, they've identified that thought. That was easy to identify. But what's behind that? What's below that? What's at the, you know, right at the foundation of your psyche? What is it? But that's difficult to get to, and it takes time. So it is developed in levels. There is a strong emphasis on empiricism in CBT. So there are beliefs and thoughts that need to be tested out. Essentially within that, in the formulation, it could be, when we get to the example, it will make a little bit more sense. But the idea is that if we have these negative thoughts, let's say it's I'm afraid people will laugh at me, well, let's test that out. Let's actually set up an experiment where you go and find out if that does happen. And if it does happen, how does it make you feel? How do you react? And the idea is that you go and find evidence for it. And also it's complementary to psychiatric diagnoses. As I've said, you know, it's been applied to various different diagnoses. Yeah, that's how it is. So let's have a little look at what a CBT formulation might look like. It can be very different, but it will always have this in it. It will always have like a situation or a problem, and it will always have this. They call it, I don't think it's a particularly professional term, so don't necessarily start saying it in interviews. But the hot cross bun. So the idea that thoughts, emotions, physical sensations, and behaviour all interact with each other. That is the core behind it. But what you will also have are things like early experiences, things that were really difficult or negative early experiences, core beliefs, and associated rules for living. So if my core belief about myself is I am destined to be alone, a rule for living might be to avoid any distress, I won't go on dating apps and I won't try and find love because I'm going to be alone anyway and I just want to save myself the heartache. So that rule for living is limiting how you live your life and potentially keeping you away from a lovely relationship. So that's rules for living. And then maintaining processes. So what is maintaining this cycle? How is this being maintained? Are there external things that help, you know, that are contributing to that? Is it particular situations? But that is a sort of very basic CBT formulation. There are lots of different types that you can get, and I would encourage you to have a little look, but most CBT formulations will have this. If not the bits on the side, it will definitely have the hot cross bun bit on it. Let's look at an example then. Now, I've chosen to look at social anxiety. Okay. And I've just made it really simple. So there are loads of different thoughts and emotions and all of that. There are loads of different ones, but I've made it really, really simple for this. So let's imagine you're seeing someone and the situation is social anxiety. The thoughts might be, everyone is judging me. That might be their thought. Everyone around me is looking at me and they're judging me and they're going to laugh at me. The emotions that go along with that might be fear and anxiety, could be shame, could be worry, could be anger. And the physical sensations could be sweating, could be blushing, could be breathlessness, heart rate increases, feeling twitchy, needing to move, feeling, all that anxiety response that's been triggered. And the behaviour, therefore, might be avoidance of social situations so that you don't feel like this, so that you don't think these things, so that you don't feel that way. And so let's look at early experiences. An early experience could be being laughed at in class, being asked to read your answer out and you made a mistake or you struggled with reading or something and the class laughed at you. Could be that that leads to social anxiety and everyone's going to laugh at me. Very, very common. Your core belief might be other people will hurt me. And I don't mean physically. I mean other people are not to be trusted. Other people are going to laugh at me. They are going to hurt my feelings. Other people are dangerous. Other people are not to be trusted. That sort of core belief. And the rule for living might be I'm not going to speak in crowds. You know, I'm not going to speak when I'm in a lesson. I'm not going to speak when I'm at work in a meeting. I'm just not going to speak because I'm going to embarrass myself. And the maintaining process could be avoidance. You're avoiding it. So therefore, how do you ever know you're not challenging the anxiety? So how do you ever know? So how do you ever know that the anxiety won't decrease and that actually if everyone is judging you, so what? What's the problem with that? You're never testing out your hypothesis that everyone is judging you. So you're always going to think that everyone is judging you if you never test it out, because you're avoiding it. So that's kind of the idea of a CBT formulation. It will usually be a lot more detailed than that, but I hope that kind of shows you a little bit about CBT. Now, moving on, we're going to look at psychodynamic. Firstly, there is no single psychodynamic theory, and therefore no single way of formulating in this approach. It can be quite varied. So psychodynamic approaches assume that psychological distress arises from unconscious conflicts within us, which I will explain a little bit. It identifies key conflicts that repeat across different contexts and relates them to main past relationships, development, and attachment. This is what a formulation does. So it'll identify key things that are going on and look at whether this has happened before in previous relationships or experiences, and how that's affected you now. It also validates hypotheses about the unconscious by observing how they play out in the therapeutic relationship and the therapist's experience. So what we mean by this is, if you've ever heard of transference or countertransference, then that's what we mean. If you don't know what it is, that's fine. Transference is, you know, when you are talking to someone in a room and you just get the feeling that they're not listening to you or they're not sure what you're saying, and it kind of transcends above body language. It's not, you know, they could be sitting blankly. You might think, oh, I think they're getting a bit angry with me. I think I'll stop talking, or something like that. That's kind of transference. Or when you're walking into a room and there's someone else in there and you immediately pick up on how they feel. That's transference. That's what we mean. In psychodynamic theory, transference is when the client redirects their thoughts and emotions about an early relationship onto their therapist. And it's often like a parental relationship that they've had. So let's say you're a psychodynamic therapist and you're seeing someone for social anxiety. And let's say you have social anxiety because your parents put you down a lot and said that you will never be successful, that other people are going to hurt you, that you can't trust other people, that sort of thing. So what the person might do, because you look to your parents to get information about the world, to learn everything about the world. So the client might do that to the therapist. They might ask them more questions. They might seek reassurance. They might seek praise. They might want to impress them. And this is all sort of unconsciously, but that's kind of what we mean by transference, is the client is transferring previous experiences of relationships onto the therapist and acting that relationship out now as a way of processing. Now, countertransference is when the therapist redirects their emotions towards the client, often in response to transference. So let's say in that example, the client is transferring on that they're kind of seeking reassurance from the therapist. The therapist, in their relationships previously, they might have had to give reassurance when they didn't want to. Then they might react in a more dismissive way than they previously had. But it's important that these things are named, because we're talking about the unconscious here. So making us conscious of what's actually going on is really important. I hope that makes sense. If you want me to do a full-on video about psychodynamic, I'm absolutely happy to do that, because it's one of the more misunderstood models, I think. Okay, looking at formulation then. What we come onto is triangles of conflict, is what these are called. Okay, so we have a past relationship, we have defense, anxiety, and a hidden feeling. The psychodynamic is all about a hidden feeling that you've got, the unconscious, the hidden conflict that's going on within you. So, for example, let's say the hidden feeling is anger towards someone's mother, their primary caregiver, for a lack of protection from a difficult experience. Let's say someone was abused by their stepfather when they were younger. Okay, so they're coming in for some psychodynamic support with that, and they're angry because their mum did not protect them from that, even though they knew nothing of it. They were not complicit in it, they were not able to protect them, and that's what a parent's role is. So that hidden feeling might be anger towards mother, but that might be something that's buried under layers and layers of stuff within someone's psyche. They may not realize that they are angry, so that's the hidden feeling. And the anxiety side might be an unacceptable urge to shout at them. And it conflicts with the need that you have from towards your parent for love and support. You don't want to scream and shout at your parent unless you're like 13 years old. Sorry, Dad. I'm sorry, Mum. But it's the unacceptable urge to shout at them versus the need for love for that person and the acceptance from that person. So the defense is to project similar feelings onto partners and friends. So actually, my mum wasn't even there to support me, so I'm going to make sure that everyone else isn't there to support me. I'm going to point out that nobody else is there to support me because that fits with my script and that makes sense to me because my mum didn't love me enough to protect me. I've got to make that okay somehow, that sort of thing. I hope that kind of makes sense. So the inherent conflict for that case is I resent you, but I'm afraid I will destroy our relationship, which I need and depend on if I bring up my feelings. So that could be the past relationship. Moving on to the current relationship, then we kind of project it on. So current relationships, we look at past relationships, other, and therapist. Okay, so past is as explained, so we've got that triangle there. Other could be friends and family. So how are those friends and family relationships played out with others in your life? If you are seeking reassurance and seeking love and seeking protection from your mum, if that's what you wanted way back when, it might be that that's what you look for in other people now. It might be that, from bosses, you might test the boundaries and see if they're actually there. Like with friends, are they actually there to support me? I better test those boundaries. And with a therapist, how is that relationship being played out or reproduced in the therapy room? Is the therapist the authority like your parent is? Are they a symbol of hope and a symbol of protection because they have a duty of care? Essentially, psychodynamic is all about how past relationships are played out currently and in what way and what unconscious conflicts are coming up and how we process those. So that's kind of what a psychodynamic formulation will be. And just to say, CBT and psychodynamic both place the cause of the psychological distress within the person. So for CBT, it's your thoughts, your emotions, your sensations, your behaviors. For psychodynamic, it's within us. It's our internal conflicts. So we're going to look at a different model. We're going to look at systemic because that places things outside of the individual. So problems are regarded as residing in relational processes as opposed to within individuals, typically within a family. So problems, are regarded as residing in the system that you are in, whether that's a workplace, but most often it's family. Quite often it's family systemic therapy is quite often what it's known as. So this usually is worked. You will see systemic approaches when working with children, because they are in that system. They're in a very sort of usually structured family system, can be, or even living in care. That's a different system. So yes, that's the sort of inherent difference between systemic, psychodynamic, and CBT. But in systemic, formulation is seen as centrally concerned with exploring the meanings, understandings, and explanations that members of the system hold about the problem. So let's say we've got a problem child. Let's say they're kicking off in school. They're not behaving. They are screaming and shouting at their teachers. And the school have raised concerns with the family and referred them to a family therapist. Let's say that's what it is. So the formulation is basically about finding out the different meanings that every member of the system gives to that problem. So the child might think that they're acting out because they feel a certain way. They feel angry. They don't really know why because they're quite young. They can't verbalize that, so they act out. Could be that. So that the formulation will consider that. It will also consider, mother's perspective or father's perspective, guardian's perspective. So it might think, one parent might think, oh, it's my fault because I act out at home and I find it really difficult to control my stress at home, and they're just copying my behavior. The other parent might think, actually, I'm not very emotionally available for my child. Maybe I'm working too hard, so I'm not able to spend time with them. So each member of the system will have different ways that they look at the problem. So formulation is all about seeking out those meanings that people attribute to the problem. And formulation is active, it's recursive, it's collaborative, and it's dynamic. So it's all to do, everyone's on a level playing field with the therapist, the family. You're just trying to work out the problem together. As I said, collaboration is really, really important in formulation generally. Certainly in contemporary ways of formulating. Family therapy, systemic therapy often involves a genogram as well. So that's kind of like a map of the family situation. So have a little look on Google for genograms, and that will kind of hopefully make a bit of sense. But that can help in the formulation to map out what's going on for the family. In terms of relationships and just a bit of family history as well. It can be really helpful. Let's information gathering and exploring meaning is seen as promoting change. Yep. So finding out as much information as possible, exploring what that means is seen as promoting change, because sometimes we don't realize stuff until we talk it through. So, and then we realize that we can make some changes about stuff. So that's kind of one of the ways, the vectors of change, if you like. Let's look at what a systemic formulation might look like. Essentially, it's looking at feedback loops and maintenance cycles. That's what the central part of systemic is. Again, this is just a really focused bit of what a systemic formulation will be, and the book has a lot more information on, so I definitely encourage you to have a look. So you have person one. You can also have more than two people. So we're looking at factors that maintain the problem. What meaning are we giving to this that maintains the problem? Because different people have different perceptions of things, and talking to each other about your perceptions of things and what maintains that problem might be helpful. It sort of posits that a lot of the time communications can be an issue in systems for lots of different reasons. Looking at a very specific example then. So there's going to be, right, the problem is you've got a mother and a daughter that come to see you, and there's some tension. Mum feels that daughter's pushing her away. Daughter feels like mum is smothering. Let's say that. So person one is Mary. She's the mother. She feels angry and she feels rejected by her daughter, who doesn't want to tell her anything anymore. Her daughter is 14. She's decided that she wants to be a bit more independent. She doesn't want to tell her mummy everything. So she is starting to close and withdraw a little bit from her mum. But Mary has the desire to control and help as a mother. She wants to help. She wants to look after her daughter and make sure that she's in control and do her job as a protector. But Sarah, the child, she actually just really wants independency. That's meant to say independency. Like, she wants to be independent, and she's actually got quite a lot of regret going on for her as well. So this is an example of what is maintaining the problem. Sarah wants independent. She wants to be independent from her mum. Actually, she's too young to be independent from her mum at the moment. And Mary has a desire to control and to help. So that's a vicious cycle. It's just maintaining the problem. So the idea about that formulation is presenting what the problem is, and then together you can all work on different ways that can be sorted. I hope that kind of makes a bit of sense with systemic. Now we're going to look at integrative. This is a super brief introduction, okay? Because integrative essentially combines therapeutic approaches. And to be integrative, really you need to be very well trained in both, because otherwise you're kind of just going off script and doing whatever you want to do. So you need to be really fully trained in lots of different models that you want to integrate. I think a lot of the time, lots of psychologists do work integratively, and that's fine as long as you're trained to do so, which psychologists typically are. So that's usually fine. But this is just one example. Integrative could integrate psychodynamic, systemic, social constructionist, narrative, CBT, CFT, ACT. It could be anything. Anything could be integrated together. But what I've looked at a little bit here is, so you've got the problem. What is going on for the person? You've got intrapersonal things. So you've got inner conflicts, you've got thoughts, core beliefs, feelings. Then you've got interpersonal. So systemic issues, what's going on for people in society, within the family, within the organisation, within the social care framework, potentially. What's going on relationally between people? How are those relationships going? What's the discourse? What's the language that we're using to construct stuff? Situational, what's going on for them? What's going on around them? Is there domestic abuse? Is there trauma? Is there substance misuse? Is there physical health? How is this contributing to the problems or maintaining problems? What is the relationship there? Maintenance, what's maintaining the problems? Consider all elements. And then you look at causation. What has contributed to the development of the problem? How far back do we go? How long has the problem been going on for? So there are lots of different factors there. Now, formulations not just considers all these different factors, but it considers the relationship. So it could be that interpersonal, intrapersonal causing the problem, situational and maintenance are all leading to the problem. But it could be that maintenance and interpersonal factors are really important and intrinsically linked. It could be that intrapersonal and situational factors are really, really linked and very important. So essentially what I'm saying is that integrative approaches look at a range of different models. That is just one example, but you've got to be careful when integrating, because otherwise you just end up with way too many things and it becomes not very focused on what you're trying to do. But it's a wide way of looking at things as well. Essentially, you need to have a good understanding of all the different approaches, though, if you're going to do an integrative formulation. Now, I want to go on to some practical advice. So for this is for pre-qualified psychologists like me, whether you're able to do formulation as part of your everyday role or not. This is just a few little tips. Firstly, if you're doing this clinically, you need to be supervised really by a registered psychologist, and you need to be able to discuss your formulations in supervision or with the wider team. Because we're not qualified members of staff, so we don't have clinical responsibility generally. So we need to make sure that we are being supervised and that it's appropriate, that we're competent to do these things. Most assistants, most PWPs will be doing formulation work that will be supervised. So yeah, I'd encourage you to see if you can speak to any psychologist that you know that can help you get a bit more experience with it. Another thing that you could do, though, is practice on some old cases with different approaches. So this is something I've done as part of my reflective portfolio. For me personally, is I've chosen a case. I've written sort of a vignette about it, so what was going on in that case, and then I use different psychotherapeutic approaches to formulate it and see what the differences are and what different information comes up and what might have been different for the intervention plan, and then I can reflect on that as well. So that's definitely what you should do. If you don't have the opportunity to do this in your everyday life, practice on some old cases with some different approaches. As I said, you can use it to form vignettes of cases to discuss in interviews in a psychologically informed way. So once you've done that, like I've said, I've made these little vignettes. As I was given some really good advice for interview prep, is to have a couple of vignettes of cases that you can talk about really easily when you're asked to give an example. So on those vignettes, it started with a little description of what was going on, and then I'd look at different psychotherapeutic approaches to formulation, and I hope that in interviews that will help me discuss things in a more articulate and psychologically driven way. I think it will. I hope so. You can find case studies on YouTube. You can have a look for example therapy sessions. This is something I've done. You can have a look at what's example, that they use in lots of different therapy training things. There's loads on there. Then you can do your own formulation. You might not get an answer as to whether it's right, but it kind of gives you a bit of a practice to know which bits of information to kind of pick out. But like I've said, formulation should be collaborative. So doing it that way isn't as collaborative because you haven't got the person there in front of you. But, still, it's a way of practicing those sorts of skills. Keep it as part of a reflective portfolio. As I've said, if you have ever watched any of my videos before, I will wholeheartedly encourage you to keep a reflective portfolio because it's the best thing I've ever done. So definitely do that. And self-formulation. So I would choose an aspect of yourself that you're happy to think about, but it's not going to be too distressing to think about, because doing it personally, I think we're always going to be subject to our own biases. But it's a good way of practicing, and it's a good reflective activity for you. So it will kind of get you used to using different psychotherapeutic approaches. So you can choose an aspect of yourself, and formulate it and think about it using different approaches. That might be helpful for you. So that's a little bit of practical advice, but my main takeaway is if you're doing it clinically with clients, you need to make sure you're being supervised. If you're in a role like a support worker role that does not, have much access to a clinical psychologist, don't start doing formulations, because you need to make sure that you're being supervised, basically. Now, moving on to some helpful resources. That is the book that I mentioned. It's fantastic. Highly recommend. Johnson and Dallas. It's the formulation in psychology and psychotherapy. Now, there's also some fantastic formulation videos on my reflective journal. I will link them down below. They are fantastic. Highly recommend. It's a webinar with 2 assistants. I think it's Rachel and Saba, I could be wrong, and Dr. Emily Barney, who's a clinical psychologist. So absolutely have a little look. And also psychology tools. There are some example formulations on there. Have a little look. Just Google psychological formulations and you'll get some blank templates, or you can make your own templates. That's what I've done. So yeah, there's some helpful resources. I hope it helps. Thank you so much for watching. I really appreciate every single person that watches. Make sure you follow us on all of the social media and click subscribe, and you will get all of the updates for all the videos. Thank you so much for watching, and I'll see you next time. Bye.